right. Good morning, good afternoon, good evening, everyone. Thank you for joining us today to mark this year's Patient Safety Day. We trust that the previous sessions from the other chapters and regions have been of interest and have contributed meaningfully to your effort to ensure patient safety, particularly as it relates to children. My name is Comfort Ogar. I am a Senior Pharmacovigilance Manager with the United States Pharmacopoeia, and I am the President of the Africa chapter of ISoP. I am delighted to host this year's event for the African region. On behalf of the International Society of Pharmacovigilance ISoP, we are very pleased to welcome you to the 6th edition of the ISoP Patient Safety Day event, holding between today, September 18th, and tomorrow, September 19th, 2025. Now, the World Health Organization has designated September 17th as the World Patient Safety Day to enhance public engagement in patient safety and to promote global actions aimed at preventing and reducing harm associated with healthcare delivery. This year, WHO has chosen the theme, Safe Care for Every Newborn and Child, under the slogan, Patient Safety from the Start, to highlight the vulnerability of those from birth to 9 years old to risks and harm resulting from care that is not adapted to their age, size, health condition, and context. Together with WHO, ISoP calls all parents, caregivers, healthcare providers, healthcare leaders, educators, and communities to unite in action to prevent avoidable harm in pediatric care and to build a safer, healthier future for every child. ISoP also affirms the objectives of WHO's Global Patient Safety Challenge and calls on health professionals and all stakeholders to prioritize and take early action in critical areas associated with significant harm in pediatric and neonatal patients due to unsafe medication practices. These areas include high-risk medications and high-risk situations, look-alike, sound-alike medicines, dose conversions, transitions of care, polypharmacy, adverse drug reactions, and major disruptions in the delivery of healthcare services. To get us started, our ISoP president, Dr. Angela Caro, will share her message for this year. Please take a listen.
Hi, my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Angela Caro. I am the president of the International Society of Pharmacovigilance. And with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day. And additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
All right. Thank you, Dr. Angela, for that wonderful message and for the encouragement. Now, we appreciate your attention and invite you to contribute to the broader dialogue by sharing your reflections and experiences on this year's event through social media. using the following hashtags: hashtag ISoP PSD 2025, hashtag World Patient Safety Day 2025, hashtag WPSD 2025, hashtag ISoP Online, hashtag ISoP Africa Chapter, ISoP Pediatric Safety, hashtag Child Safe Care, hashtag No Harm from Birth. Now, before I hand over the microphone to our speakers for the day, I would like to share a few preliminary information. We encourage you to actively participate in this session by asking questions. If you have any question, please put them in the chat box. We will do our best to respond to the questions as our schedule permits today. If we do not respond to your questions during this session, we will respond to all questions in a Q&A document, which will be published on our website, www.isoponline.org. This session is being recorded and will be available on ISoP's Facebook page and our YouTube channel in the coming days. Please visit these channels to view this session or any other sessions from this year's Patient Safety Day event. If you are not yet a member of ISoP, we invite you to join our international network committed to scientific and educational innovation in pharmacovigilance and to the global promotion of safe medication use. It is now my pleasure to introduce our first speaker for the day, Dr. Diallo Mamadou Madio, who will present on reporting exposure to drugs during pregnancy and in newborns. His presentation will be in French. Dr. Mamadio is a pharmacist, a pharmacovigilance consultant. He is the head of the internal pharmacovigilance unit at Ignace Dean University Hospital and president of the Guinean Pharmacovigilance Organization. He is actively involved in promoting patient safety at the national and international level. He is a certified trainer in pharmacovigilance for COVID-19 vaccines, having been trained at the Rabat Collaborating Center, where he attended the 15th Francophone Inter-Country Course on Pharmacovigilance. His recent contributions include developing Guinea's National Strategic Plan for Pharmacovigilance 2023 to 2027 and participating in the scientific evaluation of abstracts for the Canadian Conference on Global Health. He is also the author of the manual, Guide to Pharmacovigilance in the University Hospital Center. He is an active member of several professional networks, including ISoP. Now, without further ado, please welcome Dr. Mamadou to make his presentation.
Merci, Dr. Comfort. Bonjour, bonsoir, ça dépend de l'endroit où vous vous trouvez dans le monde. Je suis Diallo Mamadou Madiou, pharmacien, consultant pharmacovigilance, responsable de la cellule interne de pharmacovigilance au CHI Ignace Dean, membre de la Société internationale de pharmacovigilance, membre de la plateforme Afrovigilance. À l'occasion de la célébration de la journée internationale consacrée à la sécurité des patients, placée sous le thème central des soins sûrs pour chaque nouveau-né et chaque enfant, j'ai l'immense honneur d'échanger avec vous autour de cette thématique concernant la déclaration des effets indésirables de l'exposition des médicaments pendant la grossesse et chez les nouveau-nés. Diapo, s'il vous plaît. Pour faciliter cette présentation, nous allons faire une petite introduction où on va faire un rappel par rapport au contexte et rappeler un peu les quelques risques au cours de la grossesse et les quelques médicaments déjà identifiés lors des études présentant des risques durant les différentes périodes de la grossesse. Et nous parlerons également de la déclaration des effets indésirables et nous allons terminer par partager notre expérience, notre expérience guinéenne. Diapo, s'il vous plaît. Donc, en effet, on ne peut pas parler de l'exposition pendant la grossesse sans pour autant prendre en compte et rappeler que les prescriptions médicales chez les femmes enceintes soulèvent souvent des problématiques, des risques médicamenteux. Il est important aussi de se rappeler que la faible participation de ces populations concernées, à l'occurrence les femmes enceintes et les enfants, les nouveau-nés, lors des essais cliniques. C'est des populations qui sont sous-représentées pendant les essais cliniques. Et selon une étude qui a été menée entre 2011 et 2014 par l'Agence nationale de sécurité du médicament en France, 97% des femmes enceintes ont reçu au moins un médicament au cours de leur grossesse. En plus de ça, il est essentiel aussi de rappeler que cette tendance aux États-Unis s'élève à 64%, 55% en Afrique du Sud et 87% en Éthiopie, selon une autre étude qui a été menée entre 2013 et 2019. En dehors de ces tendances, il est important aussi de se rappeler qu'en Afrique, la prévalence de l'automédication est de 43,34%. Donc, et en dehors de ces chiffres, donc, ce qui révèle ici la complexité de l'exposition et ces tendances de l'exposition chez la femme enceinte ne sont pas souvent sans risque. Diapo, s'il vous plaît. Ce qui convient ici de rappeler les quelques événements historiques malheureux que le monde a connus. Par exemple, nous allons démarrer par l'événement du diéthylbestérol. Comme vous le savez, le diéthylbestérol est un oestrogène de synthèse non stéroïdien qui était utilisé entre les années 1948 et 1977 pour prévenir les avortements, les avortements spontanés chez les femmes enceintes. Donc, ce produit était connu sous le nom de distilbène. Et l'exposition entre ces deux années, entre 1948 et 1977, à ces produits a entraîné des cancers du vagin chez les jeunes filles exposées in utero à ces produits naturellement. Par exemple, en France, il y a eu près de 200 000 femmes enceintes qui ont été exposées à ces produits. Et parmi ce nombre, il y a eu 160 000 enfants nés de ces grossesses. Et voilà, il y a eu environ 80 000 filles qui sont nées de ces grossesses. Vous imaginez, il y a eu par la suite combien de filles qui ont développé des cancers de vagin après, voilà, suite à l'exposition à ces produits. Diapo, s'il vous plaît. En outre, il est aussi important de nous rappeler la tragédie de la thalidomide. Et comme vous le savez, la thalidomide, c'est un médicament antinausée qui était utilisé dans les années 60, entre 1956 et 1960, chez les femmes enceintes pour naturellement prévenir les nausées et les vomissements. Et suite à l'exposition à ce produit, il y a eu près de 12 000 cas de phocomélie. Et comme vous le savez, la phocomélie, c'est une malformation congénitale qui se traduit par l'absence des membres inférieurs ou supérieurs à la naissance, comme le montre, l'illustre cette image que vous voyez. Voilà, et environ parmi les 10 000 ou plus enfants exposés, 40% sont morts à la naissance. Donc, ces tragédies et ces tendances que je viens de rappeler, des risques liés à l'exposition chez la femme enceinte et la complexité surtout de l'exposition en Afrique, et à travers tous ces tragédies, ces événements malheureux que le monde a connus, par exemple, cet événement était lié, on peut dire, à un manque de partage d'informations entre les pays, ce qui fait que l'Organisation mondiale de la santé a initié le programme international de pharmacovigilance dans les années 68, dont l'objectif était le partage d'informations entre les pays. Parce qu'on se disait que s'il y avait le partage d'informations entre les pays, on aurait pu entreprendre des mesures de minimisation de risques. Donc, d'où l'importance de surveiller et de partager c'est-à-dire ces informations. Diapo, s'il vous plaît. Donc, il est essentiel, après tout ce qu'on vient de voir, de rappeler qu'au cours de la grossesse, il y a plusieurs risques, en fait, suite à l'exposition à des médicaments ou surtout à des substances toxiques au cours surtout de la grossesse, les différentes périodes de la grossesse. Diapo, s'il vous plaît. Parmi ces risques au cours de la grossesse, il y a des effets malformatifs. Et quand on parle des effets malformatifs, et comme vous le savez, 2% c'est-à-dire des grossesses, souvent dans le monde, euh, viennent avec des malformations. En fait, le pourcentage de malformations dans le monde est de environ 2%. En fait. Et généralement, c'est des malformations majeures. Et moins de 5% de ces malformations peuvent être liées à l'exposition à des médicaments. Et là, il y a ce qu'on appelle des effets malformatifs. Surtout, on parle d'effets malformatifs pendant la période embryonnaire. C'est là où il y a c'est au cours de cette période qu'on appelle aussi cette période l'organogénèse. C'est entre le 13e généralement et le 56e jour après la conception. Et donc, il y a des risques d'atteinte morphologique. C'est là où on parle voilà, de défauts, par exemple, de formation des membres ou d'anomalies du cœur, des cardiopathies. Nous avons également des effets phétotoxiques et juste au niveau du deuxième, juste après la période d'organogénèse, il y a le deuxième trimestre de la grossesse. Et là, généralement, l'impact de l'exposition ici, c'est le retentissement sur la croissance ou la maturation des os. Donc, c'est là où on observe des faibles poids à la naissance ou des atteintes rénales. Diapo, s'il vous plaît. Toujours au cours de la grossesse, il peut y avoir des effets néonataux. Et quand on parle des effets néonataux, c'est des expositions qui surviennent soit à la fin de la grossesse ou pendant l'accouchement. Et là, cette exposition peut être, par exemple, liée soit au médicament lui-même ou par la privation du médicament, communément appelé syndrome de sévrage. Nous avons également des effets à distance de la naissance. Et généralement, en fait, ces effets sont diagnostiqués chez l'enfant à distance de la naissance. J'ai donné par exemple ici l'exemple de l'exposition du diéthylglycérol et comme vous l'avez constaté, c'est des filles qui étaient exposées à la naissance, mais il y a eu des cancers voilà, du vagin après leur naissance, quoi. Vous voyez, donc ça peut arriver et c'est des risques qui concernent toute la grossesse, quel que soit le trimestre. Diapo, s'il vous plaît. Donc là, c'est un peu une image qui illustre les différentes périodes de la grossesse. Et comme vous voyez, le premier trimestre, la période embryonnaire, généralement, c'est là où on parle d'effets malformatifs. C'est là où il y a des problèmes de cardiopathie ou de défauts de formation des membres. Et puis, le deuxième et le troisième période, c'est là où on a des problèmes, par exemple, de faible poids à la naissance ou d'atteinte rénale. Et vous voyez, chez le nouveau-né, c'est là où on parle de syndrome de sévrage, par exemple. Et enfin, il y a l'exposition à distance, en fait, c'est-à-dire des événements qui surviennent à distance de la grossesse. Donc, c'est juste une image illustrative. Diapo, s'il vous plaît. En plus des risques qu'on peut observer au cours de la grossesse, comme vous le savez, il y a des médicaments qui ont été identifiés selon des études comme présentant des risques pendant la grossesse. Et parmi ces médicaments, nous avons les antinéoplasiques. Et ici, comme antinéoplasique, on prend comme exemple l'antagoniste de l'acide folique, à l'occurrence, par exemple, le méthotrexate. Donc, comme vous le savez, c'est un antinéoplasique et à faible dose, il a un effet immunosuppresseur. Donc, l'exposition in utero à ce produit peut induire une augmentation des fausses couches, des retards de croissance intra-utérin, de malformations congénitales majeures, telles que l'anomalie de fermeture du type néral. Donc, et il y a aussi de malformations des membres. Comme deuxième exemple ici, c'est les anticonvulsivants, les antiépileptiques. Comme exemple de produit ici, on prend l'acide valproïque. Et comme vous le savez, il y a des études qui ont démontré que l'exposition à l'acide valproïque peut conduire à des anomalies de fermeture du type neural et des malformations cardiaques. Diapo, s'il vous plaît. Nous avons également des médicaments phytotoxiques et parmi ces médicaments, il y a les anti-inflammatoires non stéroïdiens. Et comme vous le savez, le mécanisme d'action des anti-inflammatoires non stéroïdiens, c'est l'inhibition des COX. Et là, l'exposition in utero aux anti-inflammatoires non stéroïdiens peut entraîner l'altération de la fonction rénale du fœtus et conduire à une oligoanurie fœtale et voilà, une diminution du liquide amniotique. Comme vous le savez, ça peut être vraiment un risque. C'est pourquoi ces médicaments sont déconseillés au deuxième, surtout deuxième trimestre et troisième trimestre de la grossesse. Nous avons également les inhibiteurs de l'enzyme de conversion et les antagonistes des récepteurs de l'angiostensine D. Et ces médicaments également peuvent entraîner et peuvent présenter un risque selon des études qui ont déjà été menées d'une diminution du liquide amniotique. Donc, l'exposition pendant le deuxième et le troisième, la deuxième, la troisième, le deuxième et le troisième trimestre de la grossesse est contre-indiqué. Diapo, s'il vous plaît. Donc, en plus de ces rappels, il est important, suite à tout ce qu'on vient de voir, euh, la notion de la déclaration des effets indésirables, c'est important d'échanger autour de cette notion. Diapo, s'il vous plaît. Donc là, qu'est-ce qu'il faut notifier? Il faut notifier toute suspicion d'événements indésirables susceptibles d'être liés à un médicament, un vaccin ou à un autre produit de santé. Donc, que l'exposition, que ce soit une observation de surdosage, d'abus ou de mésusage, c'est important de déclarer, de notifier. Que le problème, que ce soit un problème de l'exposition de façon globale chez la femme enceinte, au cours de l'allaitement, chez les enfants, il est important de déclarer. Que l'événement indésirable soit grave ou non grave, attendu ou inattendu, c'est important de déclarer. Parce que, en fait, vous avez vu le problème avec la tragédie de la thalidomide, c'était lié essentiellement, c'est arrivé à 12 000 cas parce qu'il y a eu rétention d'informations, il n'y a pas eu de partage d'informations. Donc, ce qui fait qu'il ne faudrait pas dire que voilà, c'est un événement qui est mineur, on ne déclare pas, ou voilà, même si c'est une exposition par la suite de l'automédication, c'est important de déclarer. Que ce soit le circuit formel ou informel, il faut déclarer. Diapo, s'il vous plaît. Qui doit déclarer là, c'est important en tant que professionnel de santé. Aujourd'hui, c'est d'ailleurs l'objectif, c'est de nous rappeler notre rôle en tant de notificateur et c'est-à-dire de partager l'information et de ne pas garder cette information pour nous en tant que professionnels de santé, que nous soyons médecins, pharmaciens, sages-femmes, infirmiers, ATS. Donc, on doit déclarer s'il y a des problèmes liés à l'exposition pendant la grossesse et également chez les nouveau-nés et les enfants, c'est important de notifier et voire même de façon globale, toute exposition est à notifier, c'est à déclarer. Donc, les patients aussi font partie des notificateurs, les encourager à déclarer, les sensibiliser, c'est important de les sensibiliser et de leur faire participer à la déclaration de ces événements indésirables. Mais pour avoir des notifications de qualité, parfois on est amené à leur demander de se rapprocher voilà, des professionnels de santé pour une notification de qualité. Diapo, s'il vous plaît. Donc là, c'est un peu les outils qui permettent, qui peuvent faciliter aussi support de notification. Voilà, pour notifier, on a besoin des éléments. La fiche de notification, c'est l'élément de base pour notifier. Voilà, et voilà, elle contient en tout cas des rubriques qui peuvent aider au centre d'évaluer le lien de causalité. Donc, c'est l'élément, c'est l'outil de base pour notifier. Et en plus de la fiche de notification, il peut y avoir d'autres outils tels qu'une ligne téléphonique dédiée à ça. Il peut y avoir aussi des applications, des notifications par email. Donc, tous ces outils vont servir pour collecter et transmettre ces données au centre de pharmacovigilance. Diapo, s'il vous plaît. La déclaration, on déclare au niveau de la structure de pharmacovigilance disponible au sein de votre pays. c'est pas forcément de centre parce qu'il y a certains pays qui n'ont pas encore de centres nationaux de pharmacovigilance. C'est des unités, c'est des sections de pharmacovigilance. Donc, on doit déclarer à ces entités. Et si, par exemple, le pays est doté des centres régionaux de pharmacovigilance, vous pouvez déclarer à ce niveau. Vous pouvez également déclarer chez les points focaux de pharmacovigilance ou les référents pharmacovigilance au niveau des structures de santé. Diapo, s'il vous plaît. Il est important de notifier parce que la notification, comme je viens de dire, ça permet d'entreprendre des mesures de minimisation de risque. Et si c'est des notifications de qualité, c'est à travers ces notifications qu'on va mettre en place une base de données. À travers cette base de données, on peut se servir de cette base de données pour détecter les signaux et anticiper en fait et mettre en place des mesures de minimisation des risques. À travers ces notifications, les professionnels de santé peuvent avoir des recommandations à travers le retour d'informations venant des autorités et ça peut améliorer les pratiques de prescription, de dispensation et d'administration des produits. Donc, c'est dans le but de sécuriser, bien entendu, les patients. Ça permet également d'améliorer la sécurité, comme je viens de dire. Ça peut permettre d'évaluer l'évaluation continue du rapport bénéfice-risque. Diapo, s'il vous plaît. Donc là, j'ai le plaisir également d'échanger, de partager l'expérience guinéenne, ce que nous faisons en Guinée. Diapo, s'il vous plaît. Voilà, il est essentiel de rappeler un petit contexte. C'est que, en fait, la Guinée, nous avons une section pharmacovigilance voilà, qui est au niveau de la Direction nationale de la pharmacie et des médicaments au ministère de la Santé. Et voilà, côté niveau maturité, selon l'auto-évaluation de l'Organisation mondiale de la santé, la dernière auto-évaluation, nous sommes au niveau de maturité 1. Voilà, tout n'est pas encore mis en place, mais il y a quand même des acquis parce que en plus il y a des documents normatifs qui sont déjà rédigés, mis en place, il y a des lignes directrices. Et voilà, il y a récemment en 2023, nous avons élaboré un plan stratégique de pharmacovigilance. Et ça, ce plan inclut beaucoup d'aspects et surtout la formation. Donc, en plus de ça, concernant ce thème aujourd'hui, concernant l'exposition chez la femme enceinte et chez les nouveau-nés, il faut rappeler que la complexité des expositions. Pourquoi j'évoque complexité des expositions? Parce qu'en fait, ici, comme beaucoup d'autres pays à ressources limitées, il faut se dire que, en fait, en plus de l'exposition selon une prescription, les femmes enceintes peuvent être confrontées à d'autres expositions à travers l'automédication, à travers aussi la médecine traditionnelle. Donc, il faut également rappeler que voilà, l'accès, malgré les efforts qui sont fournis, il y a toujours des limites liées à l'accès aux soins et à l'information. Il y a aussi des difficultés aussi à évaluer les effets à long terme. Il y a des manques de données. Pour le moment, en fait, on est en sous-notification, il faut reconnaître, mais il y a des efforts qui sont en train d'être mis en place, déployés pour vraiment arriver c'est-à-dire à relever ces défis. Il y a aussi les croyances. Il est essentiel de rappeler qu'il y a des croyances parmi les facteurs et le contexte parce que, en fait, l'exposition chez la femme enceinte, quand une femme enceinte donne, vous allez voir, voilà, il y a une image qui illustre c'est qu'on peut se dire que voilà, à travers les croyances, les mœurs, dire que voilà, c'est tel facteur qui a fait que voilà, l'interpréter comme quoi c'est lié par exemple au djinn et autre chose qui fait que c'est difficile. Et puis, il y a aussi la stigmatisation. Prendre ses naissances, par exemple, s'il y a des malformations comme étant, par exemple, voilà, un malheur, c'est des exemples en fait. Diapo, s'il vous plaît. Donc là, c'est une image qui illustre ce que je viens de dire, parce que le mois d'août, il y a eu la naissance de ce bébé, appelé bébé sirène ici, ce bébé est né à Farana. Et par rapport, ce bébé illustre non seulement le problème lié à l'accès aux soins et à l'information, mais également le problème des croyances et puis voilà, voilà, des coutumes. Parce que quand on parle d'accès, c'est la maman, selon des interviews réalisées à travers le journal, quelques presses écrites, la maman, de temps en temps, elle partait à l'hôpital pour ses soins, mais malheureusement, ce n'est pas, en fait, elle, elle n'était pas régulière. Si elle était régulière, une échographie pouvait montrer à partir de, voilà, qu'il y avait une malformation avant même la naissance. Mais c'est à l'accouchement que les gens ont su que réellement le bébé est né comme ça. Vous voyez? Donc, ça dénote aussi, il y a eu des tollés au niveau des réseaux sociaux, c'est comme si c'est un miracle, vous voyez, donc, et la complexité de l'exposition, parce que cette femme est non seulement il faut se dire qu'elle est exposée aux médicaments, mais également, ça peut être aussi aux médicaments traditionnels. Vous voyez, donc c'est un peu difficile d'interpréter, d'évaluer le lien de causalité. Et puis, à travers certains aspects, surtout la déclaration, c'est un peu, parfois, si ça arrive, c'est des cas voilà, où on parle de stigmatisation, les gens ont peur de parler, voilà. Donc, c'est pas facile. Diapo, s'il vous plaît. Donc, parmi les initiatives que nous avons menées, en dehors proprement de ma participation à l'élaboration du plan stratégique de pharmacovigilance, nous avons également participé à la mise en place d'une étude CAP au CH INAS-DIN. L'objectif était d'évaluer les connaissances, attitudes et pratiques du personnel du CHI en matière de pharmacovigilance. Et derrière, à travers le rapport de cette étude qui a montré vraiment un niveau de besoin important lié à la formation et un niveau de besoin important à la mise en place d'une cellule interne de pharmacovigilance au sein du CHI et la disponibilité aussi un besoin en termes de support de notification. Il y a eu l'initiative auprès les autorités ont pris l'initiative de créer la cellule interne de pharmacovigilance au CHI INAS-DIN et nous avons déjà commencé à donner des formations et des sensibilisations sur la notification et disponibiliser des outils de notification au niveau des différents services du CHI INAS-DIN. Diapo, s'il vous plaît. Donc ça, c'est des images, c'est quelques images illustratives de nos activités au niveau du CHI INAS-DIN, des activités de formation et de sensibilisation. Diapo, s'il vous plaît. Donc, pour conclure, retenez que la déclaration de l'exposition aux médicaments pendant la grossesse et chez les nouveau-nés est un enjeu majeur de santé publique. En Guinée, des efforts importants ont été engagés pour renforcer la pharmacovigilance à travers des initiatives concrètes portées par des autorités sanitaires et leurs partenaires. Cependant, ces efforts doivent être consolidés et étendus. Et donc, il est essentiel que ce soit pour la Guinée, pour les pays à ressources limitées, ou en tout cas des pays qui se trouvent dans le même truc, d'intégrer systématiquement la surveillance de l'exposition médicamenteuse dans les soins prénatals, de former et outiller les professionnels de santé, puisque c'est nous, les professionnels de santé, qui sommes les notificateurs, qui sont à la base des bonnes des notifications de qualité, de renforcer l'implication communautaire à travers des sensibilisations. Donc, je termine ma présentation par un appel à mobilisation collective pour assurer une grossesse plus sûre et protéger les nouveau-nés contre les risques évitables liés aux médicaments. Merci pour votre aimable attention. Vos questions et suggestions seront les bienvenues.
Thank you, thank you, thank you so much, Dr. Diallo, for that wonderful presentation. Without a doubt, what you have presented today has been a fantastic addition to the topic of patient safety, especially as it relates to the children and the neonates that we're talking about today. So again, I encourage our listeners and participants to please put down any questions you may have in the chat, and we will attend to them during the Q&A session. And then Dr. Diallo, please would request that you turn off your camera but remain connected as we'll have a live Q&A session and we'll call upon you to answer the questions. Thank you. Now to move us forward, let me introduce our second speaker, Dr. Shaheen Akhtar, who will present on pediatric medication management at home. Professor Shaheen Akhtar is from Bangladesh. Her professional background spans over 2 decades as a pediatric specialist and a neonatologist. She has shown consistent commitment to the treatment, preventive care, and overall well-being of children and newborns in her home country and worldwide. She is affiliated with the Eman Medical College in Dhaka, where she impacts her knowledge and skills to the younger generation as a passionate medical teacher. With a focus on vaccine safety and pharmacovigilance, she has served as a member and secretary of the National AEFI Expert Review Committee in Bangladesh for over 14 years. She has facilitated various workshops on AEFI causality assessment, both domestically and internationally. She has been a member of the WHO Global Advisory Committee on Vaccine Safety since August 2022. Driven by a strong commitment to improve health outcomes for children in Bangladesh and worldwide, she seeks opportunities to contribute to medicine and vaccine safety issues. It is because of this passion and commitment that she has been motivated to share her knowledge with us today, all the way from Bangladesh. Please join me in welcoming Dr. Shaheen Akhtar as she makes her presentation.
Thank you very much. Dear audience, welcome to my presentation. First of all, good evening to you all from Bangladesh, and wherever you are, good afternoon and good morning. So my topic is pediatric medication management at home. Before going to the presentation, let us share my experience regarding the medication safety. So the safety status of my medication in children. I'll share you my experience in my hospital. In my emergency department in an evening, a 3-month-old infant was brought, found to be collapsing, cyanosed, hypothermic, having respiratory distress, and his illness was followed by mistakenly administered suppository. We were very much astonished to see that instead of giving paracetamol suppository, which was supposed to be 60 milligram, the baby was given a tramadol suppository, which was of adult dose, that is of 100 milligram. And the caregiver mistakenly thought both of the suppository, you can see on the screen that both of the suppository, she thought that the suppositories were of similar color, and moreover, the suppositories were of same size. So as I said, the baby was in a critical condition. The baby needed to put on mechanical ventilator, and fortunately, we could save the baby. So you can see that medication error can be dangerous and is not uncommon. So let us see what is happening worldwide. In every 8 minutes, a child experiences a home medication error. It is the worldwide data. And studies have revealed more than half of the caregivers gave an incorrect dose that is deviated more than 20 to 40%, especially in cases of liquid medicine, which has been prescribed. And in case of emergency visit or hospitalization, it has been found that more than 14% of the visits happened due to unsupervised ingestion of the pediatric medicines. And in this slide, you can see that mixing up of the medicines following an inappropriate instruction or mistakenly perceived prescription by the caregiver may cause a huge change in the dosing, may cause overdoses as well as underdosing errors. You can see if we do not clearly communicate the parents, if we do not clearly instruct the parents or caregivers, if we casually say that give 1 teaspoon, if we not write down clearly, parent may give 1 tablespoon and that may cause threefold overdose. And if we write down half teaspoon, if it is not clearly prescribed or clearly written, parent may give 2 teaspoons, so it may cause fourfold overdose. Likely, if we write give zero point 0.1 ml, if we do not clearly say, parent may give it 1 ml. If we do not give a starting as if we do not put a zero before the 0.1, that is decimal, parent may take it as 1 ml and the tenfold overdose can happen there. And we should not give a trailing zero. That is, if we give in here, you can see if we give 1.0 ml, if we do not write, if we give the zero after that decimal point, parent may take it as 10 ml. So here it also can cause an error. So let us know what is pediatric medication management at home. That is my topic. It refers to safe, effective, and organized administration of medicines to children in a home setting, obviously, and preferably under the guidance of healthcare providers. And it ensures a child receives, that is, a correct child, that is, a correct patient receives a correct medication at the correct time, in the correct dose, and in the correct way. And it enables other safety issues like storage and disposal in pediatric medication also. In the photograph or in the diagram, I have shown that there are, what I have said, that correct medication, correct time can be said in another way, that is right patient, right drug, right time, and right dose. All are covered by the pediatric medication management or safe medication. So now the purpose of my presentation is to discuss on the uniqueness of pediatric medication, the challenges while the caregiver administered the home medications to their children, and we will know what are the common medication errors takes place and the contributing factors that are responsible behind those medication errors. We will try to sort out some strategies and actionable solutions, and we'll try to learn what is the proper technique of administration of medicines. Let us know why the medication in children is unique. You know, we commonly say that children are not a mini adult. Rather, children have their unique physiological and metabolic system. Children, unlike the adults, metabolizes the drugs in a different way. As such, the children require different doses and formulation of medications. That is, commonly they are given syrup forms, and every child needs to individualize their dose of drugs based on his weight, age, and other factors. Moreover, the children are given very small amount of doses or small volume of doses, and as children are not that much cognitively developed, administering medication to children or infant sometimes becomes very much challenging. And for all above reasons, there are increased susceptibility to errors. There may be drug interactions, especially in cases where the baby is already given some medicines. And due to lack of some phase 3 or 4 studies in children, there may be lack of certain prescribing information of drugs because of less study in children. And there may be, because the children cannot express their problems, if we do not monitor carefully, sometimes we may miss the adverse effects or side effects. So monitoring is difficult in case of pediatric medication. In a study in 2020 performed in Palestine, it revealed that while giving medicines, parents have administered medicines in an incorrect interval in 80% of the parents, and 31% of the parents mixed medicines with different foods in an inappropriate volume. And because of that inappropriate mixing, maybe with juice or drinks, maybe with milk, because of that large volume mixture, the babies were not given appropriate doses. They have missed, because the baby did not drink all of the juice or milk. So large volume of medicines were missed. And keeping the ordinance in mind, the parents wanted to cure their baby faster, so they gave a higher dose of medicine than that was prescribed in case of 12% of the parents. So as I have studied many of the articles, the observed medication error in home medication in children have been found are dosing mistakes. These may be underdosing or overdosing both. And there were incorrect frequency or the duration of medication. There were missed doses also, and there were administration of wrong medications or wrong formulations. There were wrong route of administrations. Parents or the caregiver used incorrect preparation of medicines, and there were inappropriate storage practice. And in some cases, it has been found that parents use expired medicines. So let us know what are the root causes of medication errors. I tried to divide the errors in prescribing, dispensing, and in the caregivers part. So first, we can discuss about the prescribing and dispensing errors. There were inappropriate prescribing practices by the practitioners or physicians. There were inaccurate regarding the route. There have been seen that inaccurate pharmacy dispensing practices were there. The pharmacist did not appropriately or properly communicated related to the route, frequency, duration, and indication, and the communication was not clear to the caregivers. There were confusing measurement units, and there were, in some cases, there were alternate dosing practices. There were confusion between, for example, paracetamol, ibuprofen. If we give ibuprofen at a dose of paracetamol, it will be totally mess up and it will wrong. And there were confusion between the generic names and brand names. The pharmacist as well as the caregivers mistook the brand names for generic names. And there were root cause of medication. Another root cause of medication error was availability of the medication in more than one concentration. In administration, certain root causes are found associated with the caregivers at home. That is, it has been found that the caregiver were not very much aware about the importance of giving the right medication at the right dose and at right interval. And there were a huge barrier or the huge root cause of error in administration was limited health literacy and language barriers. And there were use of inappropriate dosing tools for liquid medications. And the parents did not understand the complex instruction given by the practitioner, physician, or the pharmacist. And at home, there were seen that involvement of more than one giver confused the medicines. And if there are more than one child in a family taking medicines, mistakenly one medicine for one child was mistakenly given to another one. So first of all, let us see what are the common issues that should be corrected in physicians' prescribing practice. We have seen, or we ourselves as a physician was not that much careful while prescribing. There were complex, missing, or unclear information in the prescriptions, and certain solutions are there. That is, following the WHO formulary, we must make the medication regimen simple as much as number of medication should be less so that the prescription becomes easier for the caregiver to follow. And if it is handwritten, in case of in our country, especially in Bangladesh or in the subcontinent, we used to write down many of the cases, we used to write down the prescription by hand. So if it is not computer typed, it should be the prescription should be written clearly, maybe in block letter, and we should write down the instruction accurately. Like rather than writing down that the give paracetamol whenever indicated or as directed, rather we should write down that give paracetamol 5 ml whenever temperature is more than 100 degree or more, 99 degree or more, or give paracetamol 5 ml when there is pain. So the instruction should be written clearly, and we should not write down any confusing abbreviations like you see here. I have written that if we write down the HS in small letter, it indicates before bedtime. And if we write down HS in capital letter, it indicates half strength. So we should be careful what is written here. We should avoid prescribing in milligrams, which may lead to complex dose amounts. Like if we write down 4.8, we should write down in ml, that is volume, and we should not write down any fraction. Rather, we should convert the whole number. Instead of writing 4.8 ml, we should write down 5 ml. We should use a leading zero so that the confusion is not there in the dosing, and we should avoid, as I have shown in a previous slide, that we should avoid as a trailing zero. There is a confusion, always there is a confusion in timing of medication, and it has been seen in studies that if we give instruction in the prescription to give a medicine 3 times a day, or if we write down 8 hourly, it creates confusion amongst the caregivers. 3 times a day, a parent can perceive that the 3 times can be given within a period of daytime, and within a period of 8 hours, the parents complete the 3 times schedule. And if we clearly write down strictly, we remain strict on 8 hourly or 6 hourly, it may happen that the parents are awakening the baby from sleep and baby's sleep is disturbed. So seeing these difficulties in timing of medication, it is better to use universal medication schedule, that is UMS approach. It has been instructed or advised to write down the frequency using 4 specific times of the day, that is morning, noon, evening, and bedtime. If we ask a baby, if we ask a caregiver to give 3 times a day, we can say give the medication in morning, noon, and bedtime. If it is instructed, if it is needed to give twice a day, we can say that give in the morning and evening. Instead of number of time, it has seen that it improves the caregiver's understanding, and it improves the compliance of the medicines. Regarding, there is an advancement it has been used in developed countries. In our country and the lower middle income countries, especially, I have not used in other than the few corporate hospitals. In government hospitals, because of the crowd and overload of patients in the OPD, even in the inpatient department, it is difficult to use. But we can proceed to adopt the use of electronic health record. It is very much beneficial in sense that it provides comprehensive oversight in all medications. That is, what are the medications has been given to the baby, and what is adjustable dose, and what is the appropriate dose. It can prevent, as because the electronic health record has the records, it can help to prevent drug interaction and discontinues the drug whenever it is unnecessary. It maintains the records of allergies and any prior drug interaction, and it provides, because the age of the baby is recorded, kept record over there, so it provides clear evidence for age-related indication of drugs. Pharmacist dispensing practices should be perfect. A pharmacist should provide clear instruction to the caregiver, and the instruction should be understandable language. That is, it is said that you should use drawing room language or living room language, and it should be simple, it should be understandable. The pharmacy software can be used, which must have connection with the physician's software or the physician's or practitioner's computer, so that the practitioner can send direct instruction to the pharmacist. And what I have already said, that we should adopt a universal formulary adapted for our own country, for a particular disease, for a particular age. So it will limit the number of medication and appropriately direct the concentrations available. So about what the pharmacist will communicate with the caregiver. They should provide information regarding the name of the drug, though it remains written. The pharmacist should pronounce the name of the drug clearly, and he or she should describe the indication of the drug so the parents becomes clear. The dose should be clearly uttered, and the dosing tool. So if we ask the parent to give 1 ml of certain drops, we should not ask them to use a cup. So it should be given in a dosing or medicine oral syringe, or a dropper should be advised to use. We should clear-cut tell them the route of the dose. The pharmacist should tell how frequently it should be given, once or twice or thrice a day. The duration of how many days the drug should be given, and the pharmacist should make clear about the side effects of the drugs. Like, for example, if we give promethazine, that is Phenergan, the mother or the parent should be, the caregiver should be informed that the baby will be a little bit restless or irritable, and whenever the drug will be stopped, the baby will be okay. And if there is any drug interaction, like if we prescribe the beta blocker for some condition like acute glomerulonephritis or hypertension control in children, there may be interaction with beta agonist, which has been given as bronchodilator. So we should make clear, the pharmacist should clear about the dosing, if there is any dose increment or reduction of the dose is needed. So health literacy is an important, crucial factor, and it is a great challenge in communication. Health literacy refers to an individual's ability to read, understand, and process health information. And caregivers with low health literacy faces difficulty in understanding prescription, even the over-the-counter drug levels. And it is important to recognize medication tools and understand the active ingredients information, and it helps the caregiver to understand the weight-based dosing. Even if according to in my experience, I have seen that even if a parent is well accustomed or well equipped with health literacy, if they have a very good health literacy, they may confuse. Even I have seen if a parent being a doctor, they commonly confuse about their dose because of the worriness about their kid. So being the healthcare provider, both the practitioner and the pharmacist should repeatedly communicate and clear the dose and dosing tools and frequency to the parents, despite of having a good health literacy. And especially in my experience regarding my country, I have seen that we have a good number of regional languages. So variable dialect, that is regional language, can create a barrier of understanding, and we should give appropriate attention what the caregivers want to know and how to solve their problems. And some cases, in my experience, I have seen that cultural factors may also influence drug compliance. You will be surprised to know that in our country, there is a popular belief that antihelminthic drugs should be given in a cold weather. So even if we prescribe an antihelminthic drug, the parents wait till there is a little bit cool weather or winter or rainy season, and then the parent give the antihelminthic. So we need to describe, we need to explain the parents that you can give the antihelminthic and it does not cause any harm to the baby. Advanced counseling is always crucial by physician and pharmacist. That is, in this photograph, you can see that one of our doctor is showing the mother how to give the medicines. And here the doctor herself is showing, even in a crowded OPD, what we face in our country, in Bangladesh, there is a huge load. OPD physician may need to see 80 to 100 babies in 6 hour time. So even if there is a workload, if the doctor wants, if he or she is willing, he can demonstrate with a dropper or oral syringe or any spoon or anything, medication spoon, she or he can demonstrate easily. And moreover, we can show, or the pharmacist can show the drawing or pictures so that visual explanation can make the understanding of the caregiver more clearer. And moreover, it is necessary to teach back that we can ask the caregiver, so what you have understood, please tell me what you have understood. Please show me how will you give the medication. These teach back and show back will almost 100% ensure of proper administration of drugs. And we can provide the caregivers with some pictographic printed log so that they can keep record that how much medicine or how many days, how many times they have given. And we should always encourage the caregivers so they are not fearful, they do not hesitate to ask questions to us. And it has been seen in studies that advanced counseling enables the families to complete recommended medication administration as high as 80% of the cases. We can use online pediatric information, and we can advise the parents to use certain apps. Text messaging can also help. And leaflets and brochures can be used in case of for further educating the parents. You can see what the parents can learn from how to give eye medication, how to give ear, how to give nasal medication. It has been seen that it is of very much help. Medicine administration is always challenging to the babies. We can make it fun by interacting with, especially is less than 12 months. We can take the baby on our lap. We can cuddle them. We can play with toys. We can show the administration into the toys. We can choose options like on a babies with 3 to 5 years. We can ask them to choose options from which by which tool you will like to take the medication, like that, and we can encourage them. We can give positive reinforcement. We can reward them. In older child, we can educate and explain, and we should establish and follow a routine while medication. And as I have said already, that suitable tools are very much necessary. Appropriate dosing tool should be provided in every medication, and it is a very crucial responsibility for the pharmaceuticals. And standard tools includes, it is best to use oral syringes, cups in a larger volume medicine, dosing spoons, though it is a little bit difficult. Dropper is a very good technique to give medicines. For small dose, we can give, that is 1 to 5 ml, we can give measuring dropper or oral syringes. And for larger dose, we can give 10 to 15 ml. Measuring cup is better. And we should not use non-standard kitchen spoons. Here are some photographs of the measuring tools. And we should be aware about look alike and sound alike medicine. This is a study from our medical college. You can see that in some cases, Lemicil, that is terbinafine, it is an antifungal, has been confused with Lamictal, which is lamotrigine, is an anti-epileptic drug. So the pharmaceuticals should be aware about naming the drug alike, and the appearance of the packaging should be different in different medicines. In our country, in my experience, I have seen that the parents likes or prefers to communicate over telephone, and there be in telephonic medication, there may be a great mistake can happen. So in case of telephonic conversation, we should be cautious, and we should be clearly, if it is possible, text messaging can be there, so the medication can be clear. In case of video telemedicine, there may be technological shortcoming due to poor internet connection. There may be mistakenly given drugs. We should be aware about that. And we should not be confident about the over-the-counter drugs. Before giving over-the-counter drugs, parents must consult a healthcare professional, read the label carefully, use the correct dosing tool, and keep a medication log. And even then, though it is a OTC drug, the parent should be aware about the side effects and dosing. So proper medicine storage is very much crucial. The pharmaceutical be aware about a child-resistant cap. Babies can twist off the bottle easily. We should have a child-proof lock in our cabinet, and we should not leave the medicine on the counter because the babies are very much curious. We should remind our visitors, like grandparents or babysitters, to put away their medicines, and we should not keep any expired medicine in our house. Disposal is very much important. Wherever required, we should dispose the medicine off, and we should, after reconstitution of these certain antibiotics, we should dispose after 7 days. So here is a very beautiful diagram which indicates what I have said already. That is, we should have child lock cabinet. It should be original bottle, and a child lock will be in the container. So out of children reach will keep our children's out of dangers, and awareness and alertness is the key of safety and safe medication. We should be prepared for if any emergency, if there is any. Recognizing the signs of overdose, we should teach the parents, we should train them regarding the signs of overdose. Parents should be trained up on primary management, and we should have written in a visible place where we should write down the poison control contact, and we should always report medication error or adverse drug reaction error. It is crucial. So my take home message, it is a big list, though every point is important, I think. So pediatric medication management is a shared responsibility from the pharmaceutical companies to physician and caregiver. Standardized prescribing and dispensing practices are very much essential. The prescription and the communication should be simple, clear, and the communication must be encouraging, and the communication should include teach back and show back pictorial aid. The proper measuring tool should always be available, and application of the digital solution can be practiced like emergency electronic health record, certain apps and reminder apps is promising. Safe storage is essential, and current disposal of medicine is important. And we should prepare ourselves for any emergency, and we should report any adverse drug if there occurs. So we should correctly apply, correctly administer babies. Every medicine should be properly administered every time. And again, safe care for every newborn and every child. Thank you very much for your attentive listening.
Wow. Thank you, thank you, thank you so much, Professor Akhtar, for your wonderful presentation.
Welcome.
This
Welcome.
is a highly relevant and practical presentation that will help us to advance the safety of our pediatric population. Thank you so much. So we kindly remind the audience to submit your questions for Professor Akhtar in the chat and to continue the conversation on social media using the hashtags that we mentioned previously. And I don't know if they're being displayed on the page, but hopefully they will be soon. So we now invite all our speakers to turn on their cameras to respond to some of the questions that we have from our audience. So welcome back, Professor Akhtar and Dr. Diallo. I also know that we have Dr. Ibrahim Toure, who will be translating the questions from French or from English to French, or the answers from French to English as required for Dr. Diallo. So please do turn on your cameras and we will go to our chats to look for any questions that we have. I will start with shooting off the first questions. I think I will start in accordance with the presenters, how they presented. My first question will be to Dr. Diallo. And given your presentation, which was in French for the most part, but I'm curious to, and my apologies if this was already covered. But I'm curious to understand if there are specific pharmacovigilance systems or registries that have proven particularly effective in capturing and analyzing pregnancy and newborn exposure data, either in Guinea or even in the African setting as a whole.
Can I translate? Dr. Diallo?
Dr. Diallo, do you need that translated? Well, yes, Ibrahim, please go ahead and translate.
Thank you so much, Dr. Comfort. Good morning, everyone.
Yes.
Just to say you, I am not a professional translator. I just try to help, And so, Dr. Diallo, Dr. Comfort demande s'il y a une pharmacovigilance active en Guinée ou en Afrique qui capte des informations liées à la pharmacovigilance pour les nouveau-nés. En gros, c'est ça. Merci.
Merci, Dr. Comfort. Merci pour votre appui. En fait, à ma connaissance, c'est vrai que la pharmacovigilance.
Is it my connection? But Dr. Diallo is
de
not
façon
coming through.
globale en Afrique, c'est vraiment un challenge. Il y a assez de défis concernant la mise en
Diallo, je pense qu'on a un problème de connexion
la
là.
performance des différents systèmes de pharmacovigilance. C'est vrai que les
Perhaps we'll suggest to him to turn off his camera if it is on.
Yeah.
Pour
Dr. Diallo.
Allô, vous m'entendez?
Oui, on a un problème de connexion parce que là, on ne vous attend pas de la meilleure des façons. Est-ce que vous pouvez, vous pouvez éteindre votre caméra et essayer de reprendre la réponse? Oui, c'est parfait.
Allô, vous m'entendez maintenant? Ok. Je disais que la pharmacovigilance en Afrique, c'est un défi pour nous. On est en train de travailler pour relever ces défis parce que, avec surtout la bonne nouvelle liée à la création de l'Agence africaine du médicament, et déjà les pays sont en train au fur et à mesure d'aller en agence de régulation pharmaceutique. Maintenant, concernant spécifiquement la question de Dr. Comfort, liée c'est-à-dire la question liée à la grossesse, l'exposition pendant la grossesse et chez les nouveau-nés, ça fait partie, s'il le faut, des questions de la pharmacovigilance spécifique. Donc, je pense que c'est un défi. Pour le moment, à ma connaissance, spécifiquement la pharmacovigilance, pendant la grossesse, ce n'est pas développé, en tout cas à ma connaissance. Les pays que je connais déjà, mais néanmoins, si elle a une réponse liée à ça et si elle a un élément de réponse par rapport à des pays qu'elle connaisse déjà, qui ont déjà commencé à développer spécifiquement cette question liée à l'exposition pendant la grossesse. Je connais quand même le Maroc où on a, je pense, au Maroc, il y a cette question. On a même suivi des formations liées à la pharmacovigilance, la tératovigilance. Ces jeux, je pense que c'est déjà développé. Et dans certains pays où vraiment qui ont un niveau de maturité en matière de pharmacovigilance, peut-être le niveau de maturité 3, mais c'est une question très, très importante parce qu'il y a assez de défis en fait. Les défis sont énormes.
Merci, Dr. Diallo. And summary to response from Dr. Diallo in relation with the question of Dr. Comfort is the active pharmacovigilance for a newborn is a challenge. In Guinea, is not very strong. In some African countries, it's not very strong. It's not very high level. So it is a challenge. Say you have to manage with the help of African agency and some other organization to develop it in some countries. He say some African countries like Morocco, like some countries who have attained level maturity 3. Maybe in this country they have some strong active pharmacovigilance newborn, but in Guinea and some other countries it is very, very, it's not very strong. Thank you.
Thank you very much for sharing that. The second question will be for Professor Akhtar. And I think, I hope you can hear me all right.
Yeah.
All right. I think this is a very practical question that I'm sure goes through the minds of many parents and caregivers of children. How do you safely dispose medicines at home after you have used them? This is a question, I think this is something that plagues us all of the time when we have leftover medicines from our own treatment as well as treatment for our children.
Yeah, this is a very crucial point, I think. And thinking of the time limit I was given 30 minutes, though I took 35 minutes. I little touched the point. So regarding the disposal, it is very much important because in many of the cases, what I have seen in my practice that if we prescribe a baby, say an antibiotic suppository, sorry, a syrup, so baby may need it to be taken, say 1.5 bottle, and rest of the bottle we always ask the mother if we are concerned about what I have tried to mention in my presentation, especially considering keeping while we are managing babies.
Okay. I don't know what happened there. Did we lose connection or was it from my end? Did we lose Dr. Shahin?
Yeah, I think we lose it. We lose her.
All right. While we wait for Dr. Shahin to rejoin us, I will just check if Dr. Diallo, you still there?
Yes.
All right.
Yes.
We have another question for you then while we wait for Dr. Akhtar to join us. And the question is,
Sorry. I
okay,
actually I was disconnected for a while. I
okay,
was having
welcome back.
a call from my hospital. So what we do that we ask the mother that to dispose the drug and to drain it on a basin, or we ask them to mix with some non-edible agent like we in the trash of the in our kitchen, or in some cases of adults where the medicines are given in tablets form. So we ask them to return it back to the pharmacy or the dispensary where it can be reused. But if it is some medicine that is once used and it is not appropriate to use again, we ask them to drain or use it in keep it in the throw it in the garbage bag. But it is important to remind the parents while giving the medicine that you may have some extra medicine and you should dispose them appropriately of.
All right. Thank you, Dr. Shahin, for that. I do have a follow-on question for you, a very
Yeah,
crucial one on that
yeah.
disposal of medicines, especially when we're talking of antibiotics. And I'm thinking environmental safety, I'm thinking antimicrobial resistance.
Yeah.
When we dispose these things in our drains and all, there is now a movement and more awareness about the threat to the environment and how all those leak into the environment and contribute to antimicrobial resistance. Do you have any thoughts on that?
Yeah. I have a strong thought about that. Uh, these happens, especially antibiotics, these happens very little amount because it is not that high volume that will be disposed of in the drain or wherever you dispose. Ultimately, it will be mixed in, it will be drained into the water or sewerage system, whatever. Fortunately, we have very little in the pharmaceuticals. We have very little volume, say 70 ml or a maximum of 100 ml of antibiotic is there. So very little amount, and whenever we are prescribing, we write down the volume of the bottle. That is, if the baby is a small one, we ask them to take a 70 ml bottle, or if the baby is a bigger one, we ask them to take a 100 ml. Other than this concern of giving antibiotic in the children, we have in our country, we have other concern which our environmental awareness people are working with, that we have a good number, a huge number of poultry farms whereby every village have every house of a village have at least one, almost one, every house has at least one poultry farm, especially in sorry, again I am connected. So hence are given antibiotics while rearing up in the poultry. So we are concerned about that huge amount of poultry antibiotics, and hopefully we will have some rules and regulations on that, so that the antibiotics are not indiscriminately used and these are properly disposed of. It is a huge issue. Thank you, Comfort, to raise the question, and we all are concerned about that.
Thank you, Dr. Shaheen, for that. That is very helpful to know. So go take the next question to Dr. Madeo. The question is, how can the quality and completeness of reports on pregnancy and neonatal drug exposure be enhanced, especially given the sensitivity and the complexity of these cases?
Sorry, Dr. Comfort, can you repeat the question?
Yes. How can we ensure or enhance the quality and completeness of reports that are related to pregnancy and neonatal drug use? This is particularly given the sensitivity of those groups, given the sensitivity and the complexity related to those groups in particular.
Dr. Diallo, Dr. Comfort demande comment on devrait s'assurer de la qualité et de la fiabilité des informations de pharmacovigilance par rapport aux nouveau-nés, compte tenu que c'est des populations très sensibles en raison de leur âge et de leur vulnérabilité. Merci.
Merci, Dr. Comfort. Merci, Dr. Ibrahim. Pour répondre, en fait, c'est d'abord, il faut mettre en place, il faut que le système de surveillance soit mis en place et que particulièrement concernant dans les services de pédiatrie et de maternité, qu'il y ait en tout cas des outils d'abord qui peuvent faciliter vraiment la déclaration et qu'il y ait une sorte de suivi très rigoureuse par rapport en fait, à la déclaration de l'exposition pendant la grossesse et chez les nouveau-nés. Donc, je pense que, comme elle vient de dire, c'est pas facile en fait, vu que c'est des personnes qui sont très vulnérables. Il faut qu'il y ait une sorte de suivi vraiment très très rigoureuse, que ce soit qu'il y ait en fait que ces personnes puissent faire des consultations avant de prendre des médicaments, parce que le fait qu'il y ait une complexité de l'exposition, ça peut interférer sur la qualité des informations. Vous imaginez l'exemple que je viens de donner, une femme qui fréquente non seulement l'hôpital, mais qui prend d'elle-même les médicaments, qui pratique l'automédication et qui va pas voir la médecine traditionnelle, ça sera vraiment pas facile de le suivre. Donc, il faut vraiment qu'il y ait, ça revient à résumer, qu'il y ait une sorte de suivi très rigoureuse en fait. Je sais pas si ça complète, si ça, en fait, sa question, comment je veux dire, elle est répondue totalement ou s'il y a d'autres éléments de réponse.
Merci, Dr. Diallo. And summary, Dr. Diallo say, for the sensibility of this population, of this kind of population, newborn, we have to have a great system of pharmacovigilance, particularly in pediatric and maternity. So in this area, we have to give information, and so also to have some what we can say, to develop local pharmacovigilance to capture information and to capture information and to share it with a ministry and some like authority to have to take a decision. But we have to follow a great follow-up because they are newborn is a very sensible, is a sensibility population, and the follow is very important to take account this reality. So it is in summary what Dr. Diallo say for this case, for this question. I don't know if you are agree, Dr. Comfort are agree with this response, or if there are some comment.
It's okay. Thank you, Dr. Ture. Thank you, Dr. Madio, for that answer. I think it's fine. And I'm looking at the time. I think we're just about a few minutes over and rounding up. But I just have one last question for Dr. Shaheen before I let you go. I think you touched a bit on this in your presentation about the literacy levels and then given our context, particularly, I think it's probably the same thing in Bangladesh as it will be, as it is in Africa. Given the literacy and the socioeconomic context of these two places, how can the healthcare system ensure that the socioeconomic or literacy status of the caregiver does not compromise safe and effective medication management at home? Very quickly, if you can respond to that. You're on mute. You're still muted. Your microphone is showing that you're muted.
Okay, I think you can hear me now.
Yes.
Yes. So considering the health literacy, what we are thinking about that from now, what we have learned in our childhood. Can you hear me, Comfort?
Yes.
So what we have learned in our childhood, our syllabus, especially in case of primary and secondary level, is much more improved. So many of the diseases which I have seen, which I have not read in my childhood, I have seen or have taught my kids and or other younger babies as they have learned a lot about the common diseases, their managements and the common medications. They have learned a lot. So again, moreover, if we consider that they are going to be much more enriched about the common diseases and illnesses which should they learn. Along with that, we must consider or we must keep in mind that there is a huge expansion of internet facilities and social medias and TVs. Even we have seen in cartoons that the babies are going to learn a lot of about, the diseases. So not only the babies which we are going who the generation who are going to be parents in future and the parents nowadays as well, they know a lot about the disease and the medicines. Sometimes parents come to us and says that please doctor, give this investigation and I think you can give this medicine. it, will it be good for my baby? So there a lot of improvement is there and lot of scope is there to improve if we consider from the early childhood, if we consider the regular or general education, much more be enriched with the diseases and medicines, their side effects, as much as can they take or they can ingest or they can internalize the amount of the knowledge. And the parents should also be encouraged. And I have seen so many health discussions over TVs and Facebook and media, social medias, even in newspapers. So health literacy, I think, little much more better than the past few decades, and there are scopes to improve.
Absolutely. Absolutely. Thank you very much for that. There is indeed, gosh, an over explosion of information, and
Yeah.
including health literacy, as you have said, both in the conventional media as well as social media. So there's a lot of places and resources that healthcare providers, but more importantly, caregivers can turn to get information on how to manage their medications. So thank you both for that. And thank you for your time. And I'll just very quickly, being mindful of time, close us out for today. So our time has really come to an end for this event.
Yeah, Dr. Comfort, if you permit,
Yes, yes, please.
we have 2 or 3 questions on the chat, and I can just give you the translation, the response from Dr. Maju, if you
Okay.
permit, if it is possible.
Connie, do we have time can we take a few minutes?
Yes, we can have at least 10 minutes.
Oh, okay, fantastic. Please go ahead.
Thank you. We have a question from Constanza Moreno. 2 questions. The first question is, what should healthcare providers consider before prescribing a medicine to a pregnant patient? The response from Dr. Maju is, before to prescribe a medicine to a pregnancy, we have to consider some factors or consideration. The first is which quarter the pregnancy is. It is the first quarter, the second, or the 3. And so, because that some drugs can be contraindicated in the first quarter, for example, or second, or during the pregnancy. And the second factor is the historical medical. You have to ask if generally there are some problems. And the last factor is interaction, drugs interaction, because some it is drugs interaction you have to consider it before to prescribe some drugs. And the second question from Constanza is, what are the risks of taking over the counter medicine or herbal supplement during pregnancy? The response from Dr. Diallo is, during the pregnancy, to take counter drugs or herbal supplement can have a high risk of the mother and the newborn, because some drugs can give malformation, some miscarriage, or comportmental development. And so some herbal medicine, they are not usually very high SDG for herbal medicine in some areas here in Africa. So they can give many interaction when you take it with other medicine, and can be sometimes very dangerous for our healthy. So question have every time to ask the advice of a health professional before to take a medicine. It is a response from Dr. Diallo. Thank you so much.
Awesome. Thank you.
Thank you.
We appreciate that. And thank you, Dr. Diallo. And thank you to Professor Akhtar for your time. So we extend our sincere gratitude to all our speakers and to each of you watching for your invaluable time and contribution in making this year's World Patient Safety Day event, with its focus on safe care for every newborn and child possible. Please continue to share your experiences and comments about ISoP's 2025 Patient Safety Day on social media using the hashtags that we mentioned earlier. And then we invite you to join us for the next session, which will be from the European region, and it will begin, I believe, at the top of the hour. Remember that the recordings from this event will be published in the coming days. As we indicated, please visit our ISoP Facebook page or our YouTube channel to view all the sessions from this year's Patient Safety Day event, including this current session. Once again, if you are not yet a member of ISoP, we invite you to join our international network, which is committed to scientific and educational innovation in pharmacovigilance and to promoting global safe medication use. On behalf of ISoP, I wish to thank you all for your participation today, and we look forward to seeing you at next year's Patient Safety Day. Thank you. God bless.
Thank you.
Enjoy the rest
Dr.
of your day.
Bye-bye.
Thank you for your
Bye,
management.
everyone.
Thank you. Bye.
Bye.